Okay, my name's Chelsea Margiotta. It's June 8th, 2021, and this is case connections number 2. So I chose case 2 to start. So, to answer the first question, I wanted to start with what glycogen is and what it's used for in the body. So glycogen is how we as mammals store carbohydrates. And most of this is stored in our muscles as well as in our liver. Normally, when we exercise at a certain intensity or for a prolonged period of time, the glycogen in our muscles is broken down into glucose, or as it's commonly known, sugar. So the muscle glycogen is actually the first form of energy for exercise. This is achieved by an important enzyme called glycogen phosphorylase. The glycogen phosphorylase starts breaking the bonds holding the glycogen together down, and then that releases glucose 1-phosphate, which is then further broken down again into the free glucose that we need. This glucose is then oxidized to produce ATP, or as it's known otherwise, adenosine triphosphate, which alongside calcium causes our muscles to be able to contract, which lets us be able to move and to exercise. The more intense the physical activity, the more glycogen is degraded or used up. Being that you have a deficiency in this enzyme, which is the glycogen phosphorylase, only a small amount of glycogen in the muscles can be used up. So this deficiency is actually inherited, so it's something that you've had your whole life. If you wanted to be able to go on these long walks, and you have been able to do that, that shouldn't change. This can be explained by the fact that this enzyme deficiency is really pronounced during anaerobic exercise. So quick bouts of or really long strenuous exercise. So think the high intensity interval training or long distance running. This is because the primary energy source for this type of exercise is the muscle glycogen that we talked about in the very beginning and the blood glucose that gets broken down. So long and leisurely walks, they actually fall under the category of aerobic exercise. And for aerobic exercise, the primary energy source is fatty acids from adipose or our fat tissues, as well as triglycerides in the muscle, as well as amino acids from protein that we eat. Where did it go? Fortunately, muscle glycogen phosphorylase is not the only way that glycogen is broken down into glucose for the body. So glycogen, like I said earlier, it's also stored in our liver, not just the muscles. And the liver is responsible for regulating the glucose concentration in our blood. And the enzyme that's responsible for breaking down the glycogen in the liver, while very similar to that in the muscle, is not the same. So therefore, at rest or during normal activity, you won't have that low blood sugar or lack of glucose availability. So that means you will not have to plan your meals or wake up in the middle of the night. You are able to fast and regulate your blood sugar during fasted state. If you were to perform intense aerobic exercise, you are likely to experience muscle cramping and fatigue, which is similar to how people feel when they have that lactic acid buildup. However, that is not the case for someone with the glycogen phosphorylase deficiency. While you do actually produce comparable amounts of lactate as compared to someone who doesn't have McArdle disease, your lactate uptake actually exceeds that of the lactate that is released, which results in a lower net lactate level, so you don't have that lactic acid buildup. This is because with there being less free glucose available, the lactate is actually used as another energy substrate in order to produce the ATP and allow you to exercise. Okay. And my second case is case number 4. So based on the patient's reported symptoms of jittery spells, lack of sleep, hepatomegaly, coupled with her lab results of hypoglycemia, I do feel that the baby is most likely suffering from a glycogen storage disease, which causes an inability to use glycogen. More specifically, this baby would be suffering from a type 1 glycogen storage disease, which is an inherited autosomal recessive gene disorder, which isn't unlike that of the girl discussed in case 2 just now. So the glycogen storage disease type 1 typically presents in the first 4 months of an infant's life. Our patient is 2 months old. And it has symptoms consisting of hypoglycemia, swollen abdomen, fatigue, irritability, and the enlarged liver or hepatomegaly, in other words. So in this case, this type of glycogen storage disease is caused by a genetic mutation in usually either the G6PC or SLC37A4 gene, which causes deficiency in either the glucose 6 phosphatase enzyme or the glucose 6 phosphatase translocase, respectively. So this then leads to insufficient glycogenolysis and gluconeogenesis, which ends up resulting in the hepatomegaly and the hypoglycemia, as our patient, this baby, is not able to use the glycogen that is building up in her liver, and then she can't get it into the bloodstream in order to maintain her fasted blood sugar levels. Additionally, the fact that there was no elevation in blood glucose with administration of epinephrine, but there was an increase in blood lactate, is indicative of a lactate production due to altered metabolic pathways from an excessive presence of the glucose 6 phosphate. Now, normally when epinephrine is administered, there would have been an elevation in blood glucose levels, since the glucose 6 phosphate is converted to free glucose by that glucose 6 phosphatase. However, like we said, in this case, it would seem that there is a deficiency in the glucose 6 phosphatase enzyme. So these differential diagnoses of first, hereditary fructose intolerance can be ruled out mostly because of the fact that the baby at this point has only ever been breastfed, and fructose isn't present in human breast milk, which consists of galactose. Therefore, allulose B isn't involved, which would be the primary enzyme deficient in a hereditary fructose intolerance. Similarly, galactosemia can also be ruled out, as our patient has never shown any adverse reaction to the breast milk or galactose, which is again the only thing she's eaten thus far in her life. Additionally, if she were to have galactosemia, symptoms such as convulsions, irritability, poor feeding habits, jaundice, and vomiting would have been present and severe within the first few days of her life, which is really common in babies with galactosemia. It's kind of diagnosed a lot quicker. And then finally, with the glucose 6 phosphate dehydrogenase deficiency, first of all, this is almost exclusively in males, and our patient is obviously female, as well as the most common issue that would have shown up is hemolytic anemia, which is not consistent with our patient's symptoms. Also, the symptoms of this glucose 6 phosphate dehydrogenase deficiency are triggered by infections, medications, and certain foods, none of which include breast milk, which again is our patient's only diet.